So type 2 reactions are antibody-mediated reactions. But the point here is that the antibody is IgG or IgM, not IgE, not IgA, not IgD. Just IgG and IgM. After binding of IgG or IgM to cell membrane antigens, we will have some reactions. So soluble antigens cannot activate. It is not the result of indeed the cause of type 2 hyperreactivity reactions. So the antigen is a cell membrane antigen, the antibody is IgG and IgM. Those points are important. Okay, ladies? Benat, over here. I'm talking about type 2 hypersensitivities. And I told you how by binding of IgM or IgG, we can say that we have a cell, for example, a self cell, and some antigens on it, cell membrane antigens, and by binding of IgG to them, okay, we will have injury or dysfunction of target cell. So how this antibody can make injury to the target cell? We have a cell that IgGs are bound to them, or attached to them specifically. How those antibodies can damage this target cell? Ya Allah. The question is this. So, have a look here, please. Please. Type 2 hypersensitivity. I'm talking about type 2 hypersensitivity. I told you in type 2 hypersensitivity, we have antibody-mediated immune response by binding up those classes of antibody, not IgE, not IgA, or just IgG and IgM. And by binding up those antigens, those antibodies to the cell membrane antigens. The antigens are cell bound, not solubles. Cell bound. For example, it means we have a cell. There is a cell here, any cells of the body, and some cell antigens, anything that I will give you some examples. And we have activation of antibody, production of antibody against them, IgG, they are IgG. So, as a result of binding of those antibodies, IgG or IgM, to cell membrane antigens, we will have tissue or cell injury. Is clear until now? So the question is this: how those antibody can damage this cell? Thank you, that's all. Activation of complement. What else?
Opsonization.
Opsonization, it means that we have activation of macrophages.
Okay.
And also antigen dependent.
ADCC you mean?
Yes.
ADCC or NK cell activation. So we might have NK cell activation. That's all. You know this, but you should think, what do you know about antibody? You do not need to memorize everything, but you should think about what you know. Antibody can activate macrophage by opsonization, can activate NK cell by ADCC, can activate complement. So those NK cells can target, kill the cell, macrophage can release the content of its granule on the cell, and complement will lyse the cell. So again, another question. Now we have an antibody that is bound to cell membrane antigen, and then we have activation of macrophage, a complement. How complement activation can cause cell damage?
Lysis.
Lysis. So you know that after activation of complement, we will have lysis. We might have lysis of target cell. And the functions of complement. You should think about the functions. Opsonization again. What else? Phagocytosis, opsonization. No, complement. Complement, no ADCC. Inflammatory responses, that's all. So when we have a complement activation, we have opsonization or indeed macrophage, increased macrophage activation. We will have inflammatory response, and complement can lyse the target cell. We have had those kind of immune response against virus infected cell. We have had some kind of those responses against other infections. But here have same immune response against antigens on the self cell. We have unwanted activation of that immune response that we have had them against infectious agents. The process is same. The activation of complement always have same consequences. Binding of antibody to the target cell always has same consequences. Complement, opsonization, ADCC, and the rest of the story. So IgG, IgM, cell membrane antigens, and then activation of complement, activation of macrophages as a result of opsonization, and activation of NK cells as a result of ADCC leads to the tissue damage or cell damage. So the target cells are normal tissue cells. The target antigen is normal tissue cells, or indeed any self-tissue cells, or sometimes some drug antigens. Some drug antigens, by binding to self-antigen, can induce immune response. So any antigens on the cells can induce type 2 hypersensitivity. Any modified antigens. And then we will have activation of complement, opsonization or phagocytic cells, including macrophages, activation, or PMN is another name for neutrophil activation. And we will have NK cell activation mainly for ADCC, and sometimes we have a stimulation of some receptors that I'll talk about it in the next slides. Again, it's another schematic figure for that antigen or hapten on the cell. Antibody, IgG or IgM. Then again, activation of complement, opsonic phagocytosis, NK cell, or a stimulation or blocking of the receptors. All of them, you know that complement can lyse the target cell and activate inflammations. Phagocytosis can destroy the target cells, NK cell by ADCC. All of them cause target cell injury. If you know this figure from type 2 hypersensitivity, you can answer almost all questions, different kind of questions. So now I'm going to tell you some examples. Just I'm telling you from now on some examples of type 2 hypersensitivity reactions. The story of all of them is same. When I say the story of all of them, I mean the immune responses behind them. For all of them is same, but there are examples. For example, drug-induced hemolytic anemia. Anemia means reduced blood cells or hemoglobin of the blood. So hemolysis means killing, destroying of the target cell. When we say hemolysis, it means destroying of RBCs. Hem comes from hemoglobin. So hemolytic anemia, drug-induced hemolytic anemia. So this is a RBC, And then we have a binding of some drugs. They are drugs on the RBC. Some drugs can bind to RBC. After binding to RBC, they can activate immune system, and we have antibody. You can see here. This one is antibody, and this one is drug. So by binding of drug, antibody to drugs on the RBC, we will have complement activation, phagocytic cell activation, and destruction of those RBCs. Okay? Okay or not? This is an example of type 2 hypersensitivity. Some drugs can induce anemia. How some drugs can induce anemia? This is a question. How a drug can induce anemia by binding on the RBCs and activation of humoral immune responses, production of antibody, and the rest of the story. Lysis of the target cell by the mechanisms that you've been told. So, when we have antibody production, IgG mainly here, so it means that we have humoral immune response. You do not need to memorize it. Of course, antibody is produced by B cells, and B cell is the main cell of humoral immunity. When we have IgG, it means that does we have T cell help or not? For IgG?
Yes.
Yes. For all antibody except for IgM, we have T cell help. So it is a T dependent antigen for IgG. You can see here again that some RBCs are being lysed. The smaller RBCs are as a result of lysis by the antibody. Another example is myasthenia gravis. Myasthenia gravis is an autoimmune disease that the patients produce antibody against the acetylcholine receptors here. The patient will produce antibody against acetylcholine receptors. They are the junction between the neurons, neural cells. And we have acetylcholine that is produced by these neural cells, and by binding of those acetylcholines on the target cells, we will have muscle contraction. Okay? But this patient has produced unwanted antibody. This is an autoimmune disease against the receptors of the acetylcholine. So indeed, those antibodies are blocked the receptor, and they prevent the binding of those acetylcholines to bind to their own receptors. So it blocks the action of acetylcholine. So the patient will have inhibition in his muscle contraction. The antibody indeed inhibits the muscle contraction by binding to the receptors of the acetylcholine. Okay? And then, as a result of inhibited muscle contraction, the patient will have weakness in different muscles, including some eye, yield muscles, facial expressions, chewing muscles, talking muscles, swallowing muscles, and many other all the muscles. When the acetylcholines cannot bind to its receptor, so we will have weakness of the muscles. And you can see here a weakness in the muscles of eye yield. The left eye yield of this patient, it doesn't work normally, so the patient cannot keep his eyes open. Keeping eye open is made by muscle contraction. Here the muscle contraction is inhibited by antibody. Another example is pemphigus vulgaris. You will have lectures about those diseases in your clinical courses. Not now. They are just examples. The pemphigus vulgaris are bullous. Bullous disease means blistering disease. Do you know what is blister? You know? Can you tell it in Arabic? Blister, blister. A little louder. Budbade. 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 Blister is.
I think a Persian is Toval. Toval in Persian.
Tuval.
In Persian.
Oh, yeah, Taval. Thank you. Taval. In Persian we say Taval. Or Budbade. Budbade. So it's a blistering or bullous disease in the skin. You can see the budbade in different parts of the patient. The story is that the skin cells, have a look here, the skin cells are attached to each other by some proteins. It doesn't matter the name of the proteins. So the skin cells are attached to each other by some proteins, by some receptors. This way, some patients produce antibody against those proteins that attach the cells to each other. So we have some normal proteins that attach the cell to each other, and some patients produce antibody against those proteins. By binding of antibody to these proteins that attach the epithelial cells to each other, we will have separation of the cells from each other, or we will have separation of layers of the skin. Do you remember in the skin we have different layers of epithelial cells? So those epithelial cells are attached to each other, are stuck to each other, are bound to each other. And antibody prevent this attachment. So one layer of antibody separate from the other layers, and under this layer we will have fluid accumulation. That we call it a blister or bullous or budbade. And you can see here separation of the cell, detachment of the cells from each other by again antibody. Pemphigus vulgaris, type 2 hypersensitivity. And you can see here the blisters. Another disease is Hashimoto's thyroiditis. It's indeed hypothyroidism. What does this mean? Hypothyroidism. Deficiency in the production of the hormones that is made by thyroid. For example, T3 and T4. So the story is here that the patient produces antibody against some antigens of the thyroid. That's all. The patient produces antibody unwanted immune response against the antigens of thyroid, and antibody binds to the thyroid glands and destroy the thyroid gland by different mechanisms, including ADCC, macrophages, complement. Okay? As a result of destruction of the thyroid glands, so the patient cannot produce enough T3 and T4. So it will have hypothyroidism. It is called Hashimoto's thyroiditis. And there are different types of Hashimoto's thyroiditis. The thyroids try to produce a higher amount of T3 and T4 as a result of signals from TSH. As a result, it has an enlarged thyroid in order to compensate the reduction in the T3 and T4. Another example is Graves' disease. Graves' disease is another thyroid-related disease. But here, we have antibody against TSH receptor. What is TSH? Thyroid stimulating hormone. It stimulates thyroid to produce T3 and T4. It binds to its receptor on the thyroid and induce production of T3 and T4. It's inducer of T3 and T4. Okay? Some patients produce antibody against this TSH receptor. When antibodies, they are autoantibody. All of those examples are autoantibody. When they bind to own receptor, they increase the production of T3 and T4. So it's called hyperthyroidism. Okay? We have a higher rate of production of T3 and T4 as a result of binding of antibody to the receptor of TSH. This is not a blocking antibody. The antibody which was produced here in myasthenia gravis, these antibodies are blocking antibody. Those antibodies are blocking the receptor and suppress the action of the receptor. They're called blocking antibodies. But for Graves, we have a stimulatory antibody. Those antibodies stimulate thyroid cells to produce T3 and T4. Higher amount of T3 and T4. That's enough for the examples. And this table is some other examples. I talked about Pemphigus vulgaris and myasthenia gravis, Graves' disease, and some other examples. So, some transfusion reactions and transplant rejections are type 2 hypersensitivity. If you want to give a simple definition for type 2 hypersensitivity, what would you say? Give me a simple definition for type 2 hypersensitivity.
IgG and IgM that bind the antigen of target cell, normal cell, that activate complement system, normal killer cell, natural killer cell, opsonization, and so on.
And destruction of the target cell. That's the whole story. Having antibody against self-antigens, it doesn't matter the antigens of thyroid or antigens of the RBC or antigens of the kidney, different antigens, and most of them are autoimmune diseases. Most of the autoimmune diseases indeed are type 2 hypersensitivity. We have antibody against self-antigens and binding of antibody IgG and IgM here. By binding of IgG and IgM to self-antigens, we will have ADCC, opsonization, complement activation, and destruction of the target cell. No question? That's enough for type 2. Type 3. Type 3 is an immune complex mediated hypersensitivity. What does that mean?
Antigen bind to the antibody.
We have a complex of antigen. So the difference in the type 2, we have had binding of antibody to the antigen. Do you remember? In the previous one, we had again binding of antigen to the antibody. But the difference here is that the antigen is soluble. In the previous one, the antigen was cell antigen, cell-bound antigens. In the previous one, we had binding of antibody to cells. Cells are not soluble things. They are insoluble. But here we have binding of antibody to soluble antigens. Solubles in Arabic? Da'ab antigens. We have antibody against Da'ab antigens. Antigens that are soluble in the body fluids, including blood, interstitial fluid, lymphatic fluid. But in the previous one, the antigens was on the cells, on the cells, self cells, yes. So binding of antibody again mainly IgG and IgM. We will have immune complex. So what happens next after having immune complex? What happens next? So the first step was production of antibody against soluble, again in Arabic, Da'ab antigens. We will have immune complex. So what will happen next?
Opsonization.
Might be what else?
The immune system activation.
What part of immune system activation we will have? Yes, we will have inflammation. How immune complex can activate inflammation? That's right. Immune complex can activate inflammation. How? No, immune complex. Think inflammation. Binding of antibody to antigen. can activate complement system. Complement system, Ya Allah. Yes. Okay, soluble antigen, antibody binding to soluble antigen, having immune complex, and those immune complex, whenever we have binding of IgG and IgM to each antigen, we will have activation of complement. In Persian we say Ya Khoda, Khoda means Allah. Okay, then we might have macrophages activation, NK cell activation, and as a result of activation of complement, we will have inflammation and recruitment of the cells to the tissue. So, the important thing is that those immune complexes deposit or are trapped in tissue blood vessels. You know, do you remember in the tissues that blood, the plasma exit the capillaries toward the interstitial fluid, toward the cells of the tissue. Always the plasma exit the blood vessel and enter the interstitial tissue. Is that clear for you or not? It's a normal physiology of the blood circulation and feeding the cells. The artery takes the blood to the tissue, and from the capillaries, plasma exit the blood vessel to feed the tissue, the tissue cells. Is that clear or not? So, whenever we have, in normal circumstances, we have a normal exit of plasma from the capillaries to the interstitial fluid. But when we have immune complexes cannot pass through the blood vessels. It attached to the blood vessels. It deposits on the blood vessels. They trapped in the blood vessels. So we have blood vessels that so many immune complexes are attached to them, are trapped on them, are deposited on them. Can you explain it in Arabic, you please? The deposition of immune complexes in the capillaries.
البلازما طبيعتها نتيجة بالأوعية الدموية قاعد تقدر تطلع من الإبعاد مثلا الشريان تروح للانترستيشن فلويد وتصفح ما فيش داخل بس اليون كومبلكس ما يقدر يسوي هذا الشيء فشو يسوي؟ يلزق على البلد بالذات اوكي يعني ما يسوي خلاص راح يسوي ديبوزيت يصير يتفسد يعني دائما ما راح يمشي ويا الدم.
Thank you. So we have entrapment or deposition of immune complexes on the blood vessels. So we will have complement activation or macrophages activation, NK cell activation on the blood vessels. And they destroy the blood vessels of the tissues, different tissues, including glomeruli of the kidney, including blood vessels of lung, blood vessels of skin, blood vessels of the synoviums. Okay, so as a result, the patient will have inflammation in synovium. The rheumatoid arthritis like, not the disease different. It will have some symptoms similar to rheumatoid arthritis. It will have some problems in their kidneys. They will have some problems in their skins. They will have some rash on their skins. Okay? Is the story clear? So, we will have antigen-antibody aggregates or complexes. That those complexes are produced by antibody by bonding to soluble antigens. So those immune complexes deposit on the blood vessels and activate. Fixation of complement means activation of complement. Okay. Whenever you see fixed complement or fixing of complement, it means activation of complement. We will have activation of complement. In normal situation, how those immune complexes are cleared from the body? How? Yes, by macrophage. Yes.
By FC receptor.
FC receptor of what? Yes, that's correct.
APC.
No. Yes, but we need some other thing.
Complement receptor.
No. Yes, on what cell? complement receptor on RBCs. RBCs in the blood have complement receptors. The only or the main immune-related function of RBC. RBCs have complement receptor, and by those complement receptors bind to the immune complexes and take down immune complexes to the liver and spleen, and inside the liver and spleen, those immune complexes are cleared by macrophages. Okay? This was one function of antibody and complement together, and mainly complement. It is said that large immune complexes, there is no need to think about it, that's enough. Let me skip. I do not want to bother you more than this. Type 3 reactions, we might have systemic or local reactions.
Why does the immune complex doesn't go through? Why does it deposit on blood vessels?
Why?
The immune complex. It deposits on blood vessels. Why does it go through?
Because we have, in some sites, because we have filtration of plasma. We always have filtration of plasma in capillary, and plasma is trying to filter, pass through the capillaries, and those immune complexes are large and cannot pass through the capillary and stick to the capillary. They are indeed stuck or attached to the capillary. Got it? Or not?
No, that's clear.
Clear? So, we have two types of type 3 reactions. Systemic or local. It's clear. In systemic, we have multi-organ involvement. But in the local, we have just involvement of one organ. Every time we say local and systemic reactions means involvement of multi-organs. But local means involvement of one organ only. A very important example of systemic reaction is serum sickness like reactions. I'll tell you there are some important serum sickness reactions. And the other one is Artus reaction. So, soluble antigens, this is key word here. Soluble antigens, antibody, immune complexes, and activation deposition, another keyword. Those are keywords. Deposition on the main basement of capillaries, and then activation of complement system, production of those proteins of complement, activation of inflammation, and finally tissue injury. It's the whole story of type 3. And hidden some of those slides, but so this is Artus reaction. Artus reaction is a local type 3 reaction. What does that mean? We have injection of antigen, for example, in the skin here. We have antigen injection in the skin. After injection of antigen, antibodies that are there, they bind to those antigens and make immune complex in the skin and activates inflammation. Okay, the whole story is this. So, the formation of immune complex and activation of complements and inflammation, all of them occurs in the skin. And all of the symptoms are related to skin, just skin, all the symptoms. Because the formation of immune complexes and activation of complements and inflammation occurs just in the skin. So it is called Artus reaction. So we have immune complex for antigen plus antibody is soluble antigen, immune complex complement activation, and then inflammation. That this inflammation causes tissue injury. This is the whole story of type 3. So this phenomenon here just occurs in the skin, not other tissues. Just one organ is involved. So you can see here an Artus reaction, mainly the reactions in the site of injection of many drugs. Those kind of reactions in the site of injections or tissue stings or any foreign substances that go to the skin, all of them cause this kind of reaction, which is called Arthur's reaction. So this is a tetanus vaccination. After vaccination, that person have had a type 3 reaction on his skin. The systemic reaction is mainly serum sickness, and some others, mainly RA, rheumatoid arthritis, and SLE, two important autoimmune diseases that the immune system here, the immune complexes are causing those autoimmune diseases, rheumatoid arthritis and systemic lupus erythematosus. So, serum sickness is indeed a reaction resembling allergy, systemic allergy. So the reaction is similar to the allergy, but the difference is in the type of antibody and the immune response. In the allergy, we have IgE plus allergen and activation of mast cells. But in serum sickness, we have immune complexes. The difference is, so you know that mast cells from different pathway can activate inflammation, but immune complex from another pathway. But the final outcome of both of them is inflammation. So serum sickness have a reaction similar to allergy, but the immune response of them is different. Sometimes it takes time, but sometimes it's immediate reactions. So common symptoms is skin rash. It means involvement of skin, having inflammation in the skin or hives. That could be sometimes itchy. So joint pain, I told you, and swelling of the joint. I think you can see it here. We have the skin involvement, joint involvement, feeling the pain in joints, and swollen joints as well. So the main causes of serum sickness is antivenom that are injected to save the life of the patient, anti-sera used for passive immunization. Do you remember passive immunization? Write it down, passive immunization. It would be a question from passive immunization. What's the difference between passive and active immunization? I've told you it. Write it down and send me the answer. What is the difference between passive and active immunization? It's an assignment for you. The assignments have extra point for your exam.
But we don't have the...
Send me on WhatsApp. Send me on WhatsApp. Okay? The differences between passive and active immunization. Just in 3 sentences, not more. If you write more than 3 sentences, I won't check it out. Just 3 sentences, not more. And take picture and send the picture on WhatsApp to me with your name. Write your name besides the response. I do not have your numbers, so you should write your name under the response or above it. So they are the main causes of serum sickness: passive immunization and some kind of drugs. Some kind of drugs. So you can see that. Have a look here. Until now, drugs can have unwanted immune responses in different ways, including type 1 hypersensitivity like penicillin, type 2 hypersensitivity, and type 3 is another way. That's, there are serum sickness symptoms. It's a child with skin manifestations of serum sickness in different parts of his body. It's adolescent, and you can see here another symptoms of serum sickness. So again, systemic lupus erythematosus and rheumatoid arthritis, in both of them we have immune complexes. And in post-streptococcal glomerulonephritis, what does that mean? Glomerulonephritis. What does that mean?
Inflammation in the kidney.
Yes, inflammation in the kidney. So here we have the position of immune complexes in the glomerulus of the kidney. As a result of the position of immune complexes, as a result of a streptococcal infection, the patient will have inflammation in his kidney or glomerulus. So in SLE, we have unwanted apoptosis of the cells and release of soluble antigens, and by binding of those antigens and forming of immune complexes, those immune complexes activate complement in different tissues, including kidney. Again, the story is same, having soluble antigens as a result of apoptosis. Is that clear or not? That's it for type 3. Type 4. Or let me check the time. Okay. I'll explain it in the next time. Please get back in 15 minutes. Just in 15 minutes. 15 reactions, the 3 others are antibody mediated, but this one is T cell mediated, and it is called delayed type hypersensitivity, or a DTH reaction. DTH reaction is a common term in immunology textbook. Okay? So there are 2 types of type 4 hypersensitivity or DTH reactions. In the first type, we have a cytokine-mediated inflammation. It means a cooperation between macrophages mainly and CD4 positive T cells. Because CD4 positive T cells, after activation, produces cytokine, mainly interferon gamma. Do you remember interferon gamma was a macrophage activating cytokine? So we have antigen presentation through T cells. CD4 T cells will produce interferon gamma and some other cytokines, and those cytokines activate inflammation and macrophage activation. And excessive activation of those macrophages and neutrophils can cause tissue injury. This is the first type of DTH reaction. It is called cytokine-mediated inflammation. Here we have activation of CD4, production of cytokine, and final outcome is overactivation of or excessive activations of macrophage and neutrophil. And you know that both of them, for example, in the granules of neutrophils, there are some toxic materials that in normal situation they are used to kill bacteria, fungi, but here we have unwanted activation of them, so the content of granules of neutrophils can damage the tissues, and the content of granules of macrophages. The other type is T-cell mediated killing. T-cell mediated killing. It is a CD8 positive immune response, or CD8 positive mediated cell injury. Here again, we have unwanted activation. Have a look here, please. Please. Take your seats. We have unwanted activation of CD8 positive T cells against self cells, and now those CD8 T cells can kill the self cells, can damage the tissues by killing of the self cells. So there are 2 types of DTH reactions. Both of them are T cell mediated. This one is cytotoxic T cell mediated. This one is CD4 positive T cell mediated. And you know that CD4 positive T cells only produce cytokines, and by production of cytokines, they activate other cells. But CD8 T cells can directly kill the target cells by themselves. But the target here is self cells. Destruction of self cells is the final outcome of both of them. Here again, in the sensitization phase, we have presentation of APs, antigen by APCs, co-stimulators. Do you remember? Can you tell me the name of these co-stimulators? E7 and CD28. Anti-CR receptor, and this is indeed here. It's true here. And then we will have activation of CD4 T helpers, and then they will differentiate to T helper 1, and those T helper 1 will activate macrophages and neutrophils. PMNs, I told you, is another name for neutrophils, polymorphonuclear cells. So those two cells will release the content of their granules on the target cell, and then we will have destruction of the self cells. It's cytokine mediated DTH. And again, we have two phases here, sensitization and effector phase. All of this slide is explanation of the previous slide, and I've talked about them. Sometimes in type 4 hypersensitivity and in cytokine or T helper or CD4 positive T cells, DTH, we have granuloma formation. What is granuloma? No, it's a cancer-like mass of cells, but it's not a cancer. What is granuloma? Is when macrophages, it's a normal immune response. When macrophages cannot kill the pathogen, you can see here the pathogens, they try to gather around the pathogen and contain the pathogen and prevent the spread of the pathogen to the other side of the body. Okay, so we have some macrophages in the center of granuloma that they have phagocytose the bacteria, but they cannot kill the bacteria. They cannot eliminate the bacteria. So they form a structure like a cancer by surrounding the cancer, the bacteria. Okay, we have several types of macrophages over here that we have accumulation of macrophages around the bacteria indeed to prevent the spread of the bacteria to other sides of the body. So we have a mass of cells that the main cells of the mass, this mass is macrophages and T helper cells. T helper cells are supporting the macrophages, that those macrophages are accumulated around the bacteria to prevent the spread of this bacteria to the other sites or tissues of the body.
And so this is called granule?
This mass,
Yes.
you can see it here, this mass is called granuloma. And sometimes in the center of granuloma, we have some necrotic cells. What does necrotic mean? What does necrotic mean? Dead cell.
Yes.
Another type of cell, the non-programmed indeed. Apoptosis is programmed cell death, but necrosis is indeed inflammatory like cell death. So the granuloma is accumulation of the macrophages together that they cannot kill those bacteria. They accumulate around it and they are supported by T helper 1. And indeed It's a chronic immune response, prolonged or chronic immune response. And formation of granuloma in different tissues can cause malfunction in tissues. For example, if we have granuloma in the lung, so the patient have a hard breathing. The patient cannot breathe normally because granuloma has some alveolus. We have granuloma in the alveolus of the lung. Here again you can see granuloma, there are granuloma, the masses of macrophages. So granuloma is indeed accumulation of the macrophage together that they are trying to eliminate the pathogen, and they are surrounded by TLP1 CD4 positive cells. There are examples of infectious diseases that we have granuloma formations in them. Mycobacterium tuberculosis is a good example in TB, tuberculosis, in Mycobacterium leprae, in Brucella abortus, in Listeria, and in some fungi disease and some parasitic disease. We have in all of these diseases granuloma formation. So granuloma is indeed an endeavor of immune system to restrict, to contain the bacteria in the middle of a mass of cells. And this mass of cells, which is like a tumor, but it's not a tumor, this mass of cell is composed of macrophages and surrounded by TLP1 cells that are helping the macrophages. So there are some other examples of type 4 hypersensitivity, like sometimes insect venom or mycobacteria, I told you, or some haptens including nickel that is in ornaments or jewelry or chromate, and it is called contact dermatitis or contact hypersensitivity. I have some images for them that nickel in the ornaments or jewelries, some people have allergic reaction. It's not allergic reaction, it's a type 4 hypersensitivity. It's a DTH reaction against those haptens. What does hapten mean? What does hapten? What is a hapten?
An antigen. Cannot say.
That's an antigen, yes.
Cannot say.
Recognized by immune system.
Cannot induce immune systems.
Until bind to another protein like penicillin.
That's right.
Protein in the
Yes.
blood.
That's right, yes. We have a small, they are small proteins. Small chemicals, not proteins. Small antigens, mainly chemicals, that they cannot activate immune response by themselves. They have to bind, to attach to other proteins in order to activate immune system. So they are a type of antigen. Some haptens, I told you, they can induce contact dermatitis and celiac disease, and immune response against gliadin or gluten in the food. They are DTH reactions. So we have again activation of presentation of antigen to T cells, activation of T helpers, production of cytokines, and those cytokines can activate again macrophages. You know them. And I talked about contact dermatitis. Contact dermatitis is a DTH reaction to some chemicals, including formaldehyde, trinitrophenol, nickel, and some others. All of them are haptens. They're small chemicals. They are small molecules. So you can see here some images of chronic contact dermatitis, a DTH reaction in the neck of a patient that might be he has used ornaments or jewelry, nickel containing jewelry. This one is another example. You can see here. She or he might be have worn a nickel containing jewelry, and the other one, there are examples. So two forms of DTH there are. One of them is mediated by CD4 T cells, I talked about them, and the other one is mediated by cytotoxic T cells. So again, the immunological mechanisms as a summary, we have antigen and antigen induced CD4 T cells activation or CD8 T cell activation by macrophages, and CD4 will produce different kinds of cytokines, and then we have activation of macrophages and neutrophils and tissue damages. Or sometimes we have CD8 T cells responses that they directly kill the target cells and damage the tissues. So, as a summary, different types of hypersensitivity reactions. Type 1 is mediated by IgE. So 3 types of the hypersensitivity reactions are mediated by antibodies, IgE, IgG, and the third one, IgG. What is the difference between type 2 and type 3? Ladies? Soluble for type 3, but cell membrane bound are for type 2. What is the difference between type 1 and 2 other types? The class of antibody. Here is IgE, and the other one IgG and IgG, and sometimes IgM. So the cells are different. Here we have activation of mast cells, but and type 4 is cell mediated. TL/1, CTL, and sometimes TL/2. It's a summary of. That's all for hypersensitivity reactions. No question, no comments? No?